that is Sandra. Hi, I'm Heinz.
Okay, so Professor Heinz Ludwig will introduce the next speaker, Milda.
Okay, so it's my pleasure to introduce Professor Milda Lucianskine, and she's going, she's of course from the University of the Oncology and Hematology Department, is going to talk about multiple myeloma treatment and stem cell transplant experience in Kaunas. And we are very eager to listen to your presentation. So please go on and start with your presentation. Thank you for being with us.
Okay, thank you very much for very kind introduction. I'm happy to open this next session of our meeting. Of course, it's very pity that it was not able to organize this event physically, but all together. But in these circumstances, I would like to present our center experience in Kaunas University clinics and in our center. The history of our center begins in 1940. The Kaunas clinics was one of the most modern hospitals in that times, and oncology patients were treated in internal medicine department. And now our department is in this small building, but of course after many time of reconstruction. And having survived many turns of history, Kaunas clinics retained the primary purpose of the university hospital to treat patients with the most serious disease, to guarantee the possibility of medical studies, and to create and implement innovations in clinical practice. So, autologous stem cell transplantation program was started in 2015, and every year the numbers of patients are increased, and not only for the multiple myeloma patients, but also for other indications as solid tumors and autoimmune disorders. 87 multiple myeloma patients were transplanted. Some of them had tandem transplantation, some the second transplant in the disease relapse. So in total, we did 120 transplants till the beginning of the June in 2020. As you can see in these charts, many patients are above 50 years old. The median age is 60 years and slightly more were female patients than men. And the major group of the patient was ISS 2 stage, and 32% it was ISS 3 stage of the disease. Everybody knows how it's important to identify the high-risk multiple myeloma patients. Accurate identification of these high-risk patients is the first step in the improving outcomes, not only for these unfortunately individuals, but for all patients. In our center analysis, we found that 13% of the patients had cytogenetics abnormalities. The percentages of these subgroups patients correspond to the data from the other centers and from the medical literature. Based on response rates and progression-free survival, 3-drug combination, including at least bortezomib and dexamethasone, are currently the standard of care before autologous stem cell transplantation. Almost all our patients, especially high-risk patients for introduction chemotherapy, were treated with proteasome inhibitors, I mean bortezomib and dexamethasone backbone chemotherapy, adding the third agent, thalidomide, 54%, or cyclophosphamide, 32%. And it is well known that to induce a high response rate. Usually we're giving 4 cycles of induction chemotherapy, and as you can see in this chart, overall complete response were 42% of our patients, and 88% was the overall response rate. Peripheral blood progenitor cells are the preferred source of the stem cells. Here is the mobilization regimen used in our center. Cyclophosphamide 3 gram per square meter, followed by GSF from the 6th day. The median, not the slide. The median CD34 is 4.1 million per kilo, and the plerixafor was used for 6 mobilized multiple myeloma patients in these 5 years of our practice. Melphalan 200 per square meters is the standard conditioning regimen before stem cell transplantation, which was used for almost all our patients. 90 patients were treated. 27 patients due to the older age, above 70 years, renal insufficiency without the need of hemodialysis, the patients with the heart problems as prosthesis of the valve or heart amyloidosis. Also, these patients with comorbidities or 2-3 comorbidities or poor health status patients, ECOG was above 2, were treated with reduced melphalan dose, 140 milligram per square meters, because clinical trials have shown that these two regimens are equally effective and tolerable in clinical relevant patient subgroups. And 3 patients were treated with melphalan 100 milligram per square meter because of the renal impairment and the need of the hemodialysis. The assessment of response after 100 days is based on the International Myeloma Working Group criteria, and as shown in this chart, the complete response after autologous stem cell transplantation increased up to 61%, and overall response up to 98%, and this corresponds with the progression-free survival and overall survival rates. The benefit of tandem transplantation was observed in patients not achieving very good partial response or high-risk multiple myeloma patient after first transplant. The tandem transplantation was done for 20 patients in our center, and this chart shows that double autologous stem cell transplantation affects superior the complete response rate. For high-risk multiple myeloma patients, the overall response rates were increased after the stem cell transplantation and slightly increased after the tandem. The introduction of novel agents early in the management of patients with myeloma has improved the progression-free survival in frontline therapy. And after, the median follow-up of our patient is 21 months. And progression-free survival for 2 years is 65%. Of course, it could be longer, but unfortunately, we don't have a maintenance therapy with lenalidomide or proteasomal inhibitors for high-risk patients. So our progression-free survival is like this. But overall survival of 4 years is 76%, and that showed that overall survival of myeloma patients seen in clinical practice setting matched the results of the clinical trials. So I would like to thank for my young colleague, Dr. Vilma Svetitskiene. She helped me a lot with the presentation, with the charts and with the data of the patients. And of course, I would like to thank all my colleagues who are working together in this program and continuing to development the stem cell transplantation in the Kaunas clinics. Thank you very much. Any questions?
For this excellent presentation. I don't see a question now, but I would like to ask you, at this point of time, lenalidomide maintenance is not available in your transplant patients?
No, we don't have reimbursement for our patients, but maybe it seems that maybe the situation will change from the autumn, maybe we hope a lot of, and maybe we will have lenalidomide in the front line also, and for the maintenance.
Yeah, very good. Did you have any complications, any mortality during transplantation?
Yes, the complications as usually what we can see for other patients, it's the bacterial complications, central line complications as thrombosis, but no any particular complications we didn't see with our patients. We have several patients who need intensive care after stem cell transplantation, but it was.
But there was no mortality in your renal insufficiency patients, no mortality at all?
No, for renal insufficiency, it will be another talk about these patients.
Okay.
Dr. Rolandas will present these patients, and yeah.
So, Professor, thank you very much. Professor Nietzsche, are you going to introduce the next speaker?
Yes, I will be happy to introduce the next speaker if you want. So it's an honor for me to Dr. Rolandas Kebutarvichus. I hope he's there. He is the head of Hematology Department, Oncology and Hematology at the Lithuanian University of Health Science Hospital in Kaunas. And he will, his main and he has published this in different journals, is hypercoagulation pathways, thrombosis development, and he gave also different talks at different international meetings, and I'm happy that he is presenting the stem cell transplant in multiple myeloma with renal failure experiencing Kaunas. Go ahead.
Thank you. Thank you, Dieter, for such kind introduction. And I just want to share with you our first experience for transplant activity, multiple myeloma with initial renal failure. And I would like to thank Dr. Ruta Dambrauskienė, who helped, my colleague who helped to prepare this presentation, and of course our nephrologist colleagues in Kaunas clinics. They also helped us to establish this program. So renal multiple myeloma with renal dysfunction is quite frequent condition, as we see up to 50% of patients at the diagnosis can present with some signs and symptoms of renal impairment. Up to 20% have severe acute kidney injury, and approximately 259% from different studies are dialysis dependent at the time of presentation. It was shown that severe renal dysfunction at presentation is associated with early death and unfavorable prognosis. What is very important in this situation is with our nephrologist colleagues to establish correct diagnosis, of course, and different studies shows different results, but at least one study with biopsies showed that up to 33% of all multiple myeloma patients with renal lesions have myeloma cast nephropathy, so-called, and this condition often leads to acute kidney injury. Of course, other clinical situations like concomitant hypercalcemia, dehydration, or nephrotoxic drugs, contrast agents can exacerbate existing renal insufficiency. Of course, we must do differential diagnosis. Monoclonal light chain deposition disease can cause renal injury, amyloidosis, other non-paraprotein associated injuries like acute tubular necrosis or diabetic nephropathy. And the other thing, well, at least in my mind, what we have very short time for renal function improvement, so rapid restoration of renal function or achievement of dialysis independent status is associated with improved survival, at least in some studies. And we must, of course, define acute renal injury according to International Myeloma Working Group recommendation. This is the RIFLE classification with creatinine and glomerular filtration criteria, a urine output criteria, as well as a KIN classification with creatinine and levels and urine output, and this classification allows us later to compare different treatments. And as we are talking now about hematopoietic stem cell transplantation, of course, it is effective treatment in both upfront and in the salvage setting. And many reports now indicates that use of this procedure is safe and effective in multiple myeloma patients with renal failure, including dialysis-dependent patients. And regarding conditioning, it's there is a suggestion that melphalan dose is from 100 to 140 milligram per square meter. So, of course, before conditioning, we must go for induction, and at least in Lithuania, we have bortezomib-based induction therapy before transplantation, and this is now its recommendation to do this. And together with dexamethasone, we have choose different partners. In Lithuania, we had thalidomide, and as nice studies in de novo patient was presented from Leipzig, we used also bendamustin, and even in de novo patients. And now I briefly will present our 6 patients with multiple myeloma and renal injury. 3 patients were on dialysis at the time of diagnosis and also remained at the dialysis at the time of transplantation, and 3 other patients were with renal injury, and 2 of them on dialysis during diagnosis, but on transplantations we were free of dialysis. So first 3 patients on dialysis were lambda light chain monoclonal protein, 1 patient IgA, ISS revised stage 2, and akin stage 3 RIFLE class E. And for all 3 patients, biopsies were done, and myeloma cast nephropathy were diagnosed. And we started treatment for 2 patients for causes VTD, bortezomib, thalidomide, dexamethasone, and for 1 patient, bortezomib, bendamustin, and dexamethasone for 6 causes. And responses we will discuss later. And apheresis for collection hematopoietic stem cells were successful. We collected for all patients without any problems sufficient number of hematopoietic stem cells. Melphalan, it was given 100 milligram per square meter, and hemodialysis was done at the bedside, at the transplantation wards, during transplantation. And regarding cause of transplantation, engraftment of leukocytes is not different from the patients with normal renal function, about 9-11 days, and platelets as well from 10 to 12 days. And regarding response in this situation, I think we must have 2 responses. So it's multiple myeloma response, and this is defined by International Myeloma Working Group criteria. So we had this criteria. And for our dialysis-dependent patients, after induction, we achieved responses for one patient, partial response, for the second VGPR, or for second complete response. But it's very important that after autologous hematopoietic stem cell transplantation, 2 patients improved their response, and one patient which was in complete response maintained this response. So after autologous transplantation, we had 2 complete responses and 1 VGPR. And the other type of response in this situation, of course, is the renal response in multiple myeloma patients with renal function, and also International Myeloma Working Group criteria is published, and we see that we must measure creatinine clearance, and for example, for complete response, we must achieve equal or 60 milliliters per minute creatinine clearance. So for our first 3 patients, of course, after induction, all remain on dialysis, and regarding renal response, it was no renal response. And when we did autologous transplantation, 2 patients remained on dialysis, so no renal response, but 1 patient achieved minor response and no dialysis. So 1 patient of regain dialysis independence. And more 3 patients, other 3 patients were presented with renal failure at diagnosis, with 2 patients with dialysis dependence at the diagnosis, but all 3 were dialysis independent at the time of transplantation. All patients also expressed lambda light chain monoclonal protein. 1 patient also together IgG monoclonal, and different akin and refill stages. And for 2 patients, it was done biopsy of kidney, and myeloma cast nephropathy were diagnosed. And 3rd patients, just Ben John's proteinuria was observed. And during induction was administered from 4 to 6 cycles of bortezomib, thalidomide, dexamethasone. Also, hematopoietic stem cells were successfully collected, sufficient number. Melphalan 140 milligram per square meter conditioning was administered, and for 2 patients, even tandem transplantation was performed. So engraftment of leukocytes and platelets is not different when from patients with normal renal function. Regarding multiple myeloma response, again, it was 1 partial, 1 VGPR, and 1 complete response after induction, and all improved after autologous transplantation to complete response. And regarding renal responses observed already after induction, 2 patients were no dialysis, no dialysis independent status achieved, and partial and minor responses, renal responses. And after transplantation, again, these responses improved or at least maintained, and 1 patient even attained complete renal response, and other partial response and minor response. Duration of hospital stay is maybe a little bit longer, but not much from the normal renal function. No infection were observed. And in conclusion, I would say that 60% of our multiple myeloma patients requiring dialysis at the time of diagnosis became dialysis independent with bortezomib-based triplets induction and autologous stem cell transplantation. 100 days, 6 months, and 1 year treatment-related mortality is a small cohort of our patients. We are 0. And some patients significantly improved with renal responses, but also very important what we attained good multiple myeloma responses. So even without renal response, we could think maybe possible about kidney transplantation if it will be in the future. But our patients relapsed, so we didn't have this opportunity. And just for highlights, I just would like to thank our nephrologists. Of course, I must, at least I feel that we must have very good cooperation with our nephrologists to diagnose this patient as soon as possible, and to start all with effective, supportive, and pathophysiological treatment. So thank you very much for your listening.
Thank you, Rolandas. Nice results. So
thank you.
The audience should use the chat button on the screen to make some questions if there are some. So please let me open.
I have some questions. Do you do renal biopsy in all your patients, or do you diagnose cast nephropathy based on clinical findings?
Usually, our nephrologists tend to do renal biopsy. As you saw from 6 patients with renal failure, we had 5 biopsies. Maybe we must improve a little bit with Ben-Jones protein immunoelectrophoresis, because sometimes we are not in the highest level. But for biopsies, yes, nephrologists tending, and we're now discussing what we would like to have biopsy results.
Yeah. One important issue when trying to improve renal function again is the time interval from diagnosis to initiation of therapy. Can you give us your opinion on this and on the data? What was the interval between occurrence of symptoms and the start of therapy?
Thank you, Heinz. You are expert in this field, and I'm very grateful that you joined our business. So I am concerned a little bit. Of course, we must act faster. I would say maybe we are a little bit slow, because when we diagnose this condition, maybe some delays between nephrologist and hematologist, maybe even a week or a couple of that, just to initiate this treatment. So for me personally, I also very concerned, and we are talking with nephrologists. We must be very quick, and as you mentioned in all articles and all your talks. So I think we must have very good comparison. But from our some patients, of course, even we are presented in nephrology department, I think with long-lasting symptoms, like for few 3 or 6 months without any clinic, and we just arrived to hospital and creatinine 1,700 and dialysis, and after that 1 month for diagnosis, and maybe too late.
Okay, Rolandas, did you change your protocols in these patients, like in substitution of platelets or red cells, or how you manage that?
I just followed our usual maybe protocol with this melphalan conditioning adjustment. We didn't maybe had more erythrocyte transfusions or platelet transfusions, but of course we must be very careful with if we had any additional drugs.
Okay.
So your conclusion is that the renal insufficiency with hemodialysis is not the contraindication for autologous transplant, correct?
Yes. it's feasible, and this approach what we must follow, and this patient must be transplanted.
Yeah.
Okay.
Yeah, no question. Yeah.
Yeah. Thank you.
If there are no questions, I would like to hand the chair to Sandra.
Yes, it is my pleasure to introduce with the next speaker, Domas Vaitiekus. He is from Kaunas. He graduated Kaunas University of Medicine, and then after training received 2 certifications as medical oncologist and hematologist. At the moment, Domas is head of hematological stem cell transplantation section and also coordinator for cellular therapies implementation at the Hospital of Lithuania University of Health Science. Domas, please.
Hello, professors. Thank you for very nice introducing Professor Leinitze. It's nice to see you during this COVID situation, unfortunately only from the TV, yes. So I would like to present our program and our future and also radiotherapy role in the modern hematology, especially in the transplant. I would like to thank for my colleagues from the radiotherapy department for this presentation, for the Viktoras Rudžianskas, Laimonas Jaroševičius, and the head of our department, Professor Elona Jozaitytė, for cooperation and preparation of slides about radiotherapy in the transplants. I have no conflicts for these presentations. And firstly, I think everybody who are our guests here should know that we are working in the biggest hospital in the Baltic states. It's the biggest hospital in Lithuania. We have a huge number of beds, a lot of departments. Before 2015, all the transplants from the solid organs were done in our hospital, but because of the many historical issues, we didn't perform bone marrow transplantation, which has been started with the help of Professor Niederwieser and the telemedicine project. And we started project in 2015. Our staff has been trained in Leipzig. Also, we did teleconferences, site visits, and we had a very great support in the beginning and also continuing support to avoid learning mistakes and to perform very good quality transplants in our hospital. And from the beginning, our transplant numbers increased quite dramatically. Just in the first year, we did 7 transplants, and in the next year, we doubled, and we are still increasing our numbers. And I don't think so that we are reached plateau, and I hope that we will increase the numbers of transplant, especially in the allogenetic field, which has a great potential for treatment our patients. We already done 141 transplants in our hospital for 105 patients. We did our first allogenic hematopoietic stem cell transplant, about which I will tell you a little bit later. But our contingent of the patients are mostly multiple myeloma patients. The second part of the patients are patients with the lymphoma, including primary CNS lymphoma. We had also patients with solid tumors, germ cell tumors. We did also transplantation for the autoimmune encephalitis and for the multiple sclerosis patient. Most of our patients are quite good performance status with the ECOG 0, but some of these patients had a little bit lower worsened performance status, but it can let us to perform the transplantation. Age of our patients are very diverse. It's from the 18 till 73 years old, and most of the patients are between 50 and 65 years old. About the complications, we didn't have any complications that are unusual during the transplantation, and the number is with the serious complications are not very high. Only 4 our patients had been in the intensive care unit, and this number is, I think it's quite good. Most of the serious complication, we had a septic shock for the 8 patients, Clostridium colitis 4 times, atrial fibrillation 4 times. The most common complication that we see for our patients is mucositis. It's usually degree 1st or 2nd. We had also few more severe mucositis, but it's quite rare, despite we are using mostly melphalan, but with the mucositis we are quite lucky. Usually for all our patients in the autologous transplants, we used about 3.5 units of platelets and 1.2 units of irradiated erythrocytes. And we are quite lucky and happy that we didn't have any major bleeding events for our transplant patients. Our survival for all the transplants with all the diseases, malignant diseases, and also multiple sclerosis patient is for 1 year 90.7%, and the treatment-related mortality at 100 days it's quite low. It's 0.71%, and we are quite successful to managing quite severely ill patients during our transplants. Starting of our transplant program was a quite big shift for other hospital facilities and our colleagues in other departments of the hospital. Mostly we implemented a lot of molecular testing for our program for the transplantation and for the hematological malignancies, and especially thanks to the molecular department. Also, there was a great improvement in the microbiology, especially molecular disease diagnostics, PCRs. At the beginning in our hospital, it was only CMV and herpes simplex CMV PCRs, and now we can perform more than 20 for the 20 diseases, infection diseases PCRs, which is important for us, but it also was a big shift for other departments and other transplants for the solid organs to improve the quality of care in our hospital. Our timeline, what we done, we already went almost 5 years in our program. First, it was multiple myeloma patients in 2015. After 2 years, we had a permission to perform more autologous transplant, and we started with the lymphoma patients. Very soon, we started with the solid tumors, and it was germ cell tumor. In 2019, it was first patients with the primary CNS lymphoma. 2019 was also a special year. We did the autoimmune encephalitis autologous transplantation. In this year, at the beginning of this year, we did the first transplant for the multiple sclerosis, Ewing sarcoma, and it was a very important step for us during the COVID lockdown. We managed to perform our first allogeneic match-related hematopoietic stem cell transplantation. Our special transplants that we will remember, I think, many years after that, during our program, of course, Professor Gebutavičius presented our patients with dialysis. They were all special patients, and we did a lot of work with them, and we are happy about these very good results. Another special transplant, it was germ cell tumor patient. Transplant was not very something special, but the patient was very special. He had a transplanted kidney a few years ago, and with a profound immunosuppression and a lot of infection complication, it was a real challenge to perform 3 transplants for this patient for all our department. Autoimmune encephalitis with CD3 negative selection was also very important for our department and also for the laboratory for the selection. and multiple sclerosis was the first. Our cooperation with the neurologist to start treatment for these patients with the autologous stem cell transplantation, and the primary results after 3 months of this patient, we have quite good results, and we hope to present it maybe next year with the improving with the neurological situation with this patient. So our biggest achievement this year, and it was our target for these 5 years to start allogeneic hematopoietic stem cell transplantation. And this year we managed to do that. It was our patient with the Hodgkin lymphoma stage 4B with a primary refractory disease. We didn't have any other treatment options because we tried almost everything what is possible for this patient. And we were quite lucky. She had a match-related donor, HLA 10 of 10, with a minor ABO incompatibility, and also CMV negative. The donor was CMV negative. We performed conditioning with a 12-grade TBI and cyclophosphamide 120 milligrams per kilogram. Because of the ABO minor incompatibility, we performed a plasma removal and did a transplant for this patient. This transplant was very important for us as it was first allogeneic transplant, but it was also very important for our radiotherapy department because we performed first time in Lithuania the total body irradiation, myeloablative total body irradiation before the transplant as a conditioning regimen in the allogeneic transplant. Till now, in another center, they had no possibility to perform TBI, and it was the first time when we did it in Lithuania. Our department is ready to perform TBI in the myeloablative regimen or in non-myeloablative regimen, so we have a great potential to do that for our patients. This is the pictures from the planning. The planning of this patient was done by the CT scan, and realization of the irradiation was done by the intense modulated radiotherapy. Then the shielding of important organs like liver and lungs were done by the modulation, not with the physical fields, but with a very comprehensive machines that can perform and perform the saving of the important organs. This is the plan which was done by our radiotherapist and physics, which was quite impressive for them because it can compare to with about 14 usual irradiation plans. So one patient took about 14 times more time to make a plan for this irradiation for this patient, and we were very happy about ISO doses for the liver and lungs, which are very safe for the patient, and we hope to have very little late complications due to radiotherapy. Total body irradiation is a very important part in the conditioning regimens, and it takes important part of the conditioning. In the last years, it takes about 50% for the transplants. Of course, not all the centers has the ability to perform total body irradiation, but this is especially important for the patients with the leukemias and other malignant diseases which are needed to perform hematopoietic stem cell transplantation, especially allogeneic transplant. And this data that has been shown very recently, a few weeks ago in the EHA, that compared total body irradiation with the chemotherapy as a conditioning regimen for the patients with the ALL, showed that there is no big discussions that the total body irradiation is much better conditioning regimen for these patients. And 2 years overall survival can be increased by the more than 13% for these patients. So we can save more lives using these techniques. And it was long time discussion that total body irradiation can cause more side effects, late side effects, and treatment-related mortality. But this very good multicentral clinical trial showed that treatment-related mortality is not bigger and it's not increased comparing with the chemotherapy alone. And I think this should be become a standard of care. And I'm very happy that in our hospital we can perform this, and we can give the chance of better survival for our Lithuanian patients, especially with the ALL. With the using of total body irradiation as a conditioning regimen than they needed transplant in the field of leukemia. We have many plans in the future, and we are moving forward as fast as we can, as much as we can, and we do more than we can. And our plan is, we already did few steps that was very important. We started our cellular processing. We did our autologous hematopoietic stem cell transplant. And I think we will not stop with the expanding of indication for the autologous transplant and all the problems. Our molecular testing is improving every day, and we will getting new techniques and new molecular tests every week and every month. So which it's very encouraging us for the future, and we have very many hopes to do as much as possible with the newest molecular testing. I'm very happy about allogeneic stem cell transplantation, but it's not the end. We have to expand. It was match-related donor. We will start to do match unrelated donor, and I think later another step for us it should be the haploidentical transplant with post-cyclo. Donor lymphocyte infusion as a treatment option for our patients who will receive the transplants, and they will need it. We are ready to do that, and this is our step, the close step, and I'm sure that we will proceed to that. The big challenge for us is a JACE accreditation. This is our aim and our goal in the nearest few years. I hope we will manage to go to procedure for the JACE accreditation. Another big step for all our hospital, not only for the hematologists but for all our departments, is to start to produce and clinical trials and also in the research ATMP for the treatment of different hematological malignancies or even some solid tumors. And the biggest step to move for us forward is the gene therapy, which is I think the next step, or it's a together step with the ATMP implementation in clinical practice in our hospital. So many thanks for our team, and I'm ready to answer any questions if you have. Thank you.
Thank you, Dumas. My congratulations with the first transplantation. Now can you start with not the easiest way with Hodgkin disease? And at the moment, there is no question from the audience, and I would like to ask you about possibility about amount of sibling donors in Lithuania in general. Do you have donor registry in Lithuania at the moment?
I'm sorry, but I couldn't hear you because very bad connection. Okay. Yeah. Maybe Professor, can you write the question?
What is the situation with sibling donors in Lithuania in general?
Okay. In general, I think like in all the Europe, it's quite problematic because there is small families. Usually there is one or two siblings in the family. So chances to perform the sibling transplantation is very minor. From the general Lithuanian experience, the sibling transplantation is less than 15% are done from the siblings in the allogenetic field. In this situation, we were very lucky. The patient had a very big family, and we even had 2 possible siblings as donors. So we could even choose 2 donors from the siblings.
Mm-hmm.
Okay, and what about in Lithuania?
I'm sorry.
Do you have donor registry in Lithuania?
Yes, there is a donor registry, and it's yes, we have. But it's very small, and usually it's not sufficient. So about 90% of transplants, even more, 95% of match and related donors are coming from the registries in Germany, Poland, and other countries.
Okay, thank you.
So let me interrupt. So we have already 2 donors, unrelated donors, localized from Germany. So we are very close that we can localize an unrelated donor within 2 or 3 days.
Thank you, Professor.
Okay, thank you.
Thank you.
Thanks so much.
Hi, Professor Ludwig. Sorry, I interrupted you.
No question. No, I think this was a very interesting presentation, and you also addressed your future goals, gene therapy. Do you consider cellular therapy as well? For instance, CAR T cells. I know the problem regarding CAR T cells is when they are approved in Europe, probably one is obliged to use the approved product, because on the other hand, there are institutions which produce their own CAR T cells, which is of course much cheaper and gives you much more flexibility. Did you ever consider this?
Thomas, it's you.
Hello, I didn't hear it. I'm sorry.
Okay, lost. So let me respond. So we have a cooperation with a university in Europe where we are trying to produce this ourselves. And this will start soon, as soon as we have all the legal requirements.
Okay.
Yes, thank you.
I think we should move on, huh? We should thank Thomas for the excellent presentation. And who is going to introduce the next one, Dieter? Or do you want to introduce the next one?
Yeah, Heinz, it's your turn.
It's my turn. So I have the pleasure to introduce Ivea Kolopi-Karte, and she has a very, actually, she's a biologist and is, I think, responsible for the stem cell tissue bank, which is an important task among several other activities and obligations. She's a quality manager and has obviously she's very experienced in genetics and other important fields of medicine. Her task is very interesting because she's going to talk about post-Chernobyl challenges for Ukrainian oncohematology. So we are eager to hear your presentation, and thank you for accepting the invitation.
Okay, so hello everyone. I would like to correct you a little bit because I will talk about cell processing in Kaunas, and I am a biologist at the Hospital of Lithuanian University of Health Sciences Kaunas Clinics. So a couple of slides about cell processing in Kaunas. And I would like to introduce you, beginning with the role of the peripheral blood stem cell tissue bank. So the goal of it is to collect, process, and preserve cells right after the moment the apheresis is completed until the moment cells are handed over for transplantation. So what I and my colleagues do, so after reapheresis, we are responsible for cell transportation from the apheresis unit to our facilities, and also sample transportation to the laboratory for testing, and then of course the appropriate storage of the cells and documentation. And when we have the results from the laboratory, we then initiate the preparation of cryopreservation mixture. And here in Kaunas, we use the 10% dimethyl sulfoxide protocol with patient's plasma. So once we prepare the mixture, we initiate the cryopreservation process, and it is done in a control rate freezer. And once cells are frozen, we transfer them to vapor phase nitrogen tanks for long-term storage. and we monitor the temperature closely to ensure that it's appropriate the whole time. And when the patient is ready for the transplantation, we then take the cells out of the tanks, transport them to the hematology unit for transplantation, and we thaw them in a water bath. And once the cells are thawed, they are immediately given to medical professionals for transplantation. And the tissue bank here in Kaunas started its work in 2015 with the autologous stem cell transplantations. And here in this bar chart, you can see that in 2015, we had 11 patients, and then the number increased over the years. And this year we have actually not only 9, but already 11 patients. And we expect the numbers to grow later on in the year. And we also are very happy to announce that we had the first allogeneic transplantation here in Kaunas in May. And just because of that, because we had only one allogeneic transplantation, from now on I'm going to talk about the autologous transplantations. And we had 128 patients, where 69 of them were females and 59 males. And there were 288 apheresis performed, with the 405 cryopreserved products ready for transplantations. And we had 141 transplantation for patients with various diagnoses, as my colleagues already mentioned that. And we actually looked into our data, and we found that the median post-thaw stem cell viability was 78%, ranging from 42 to 96%. And then the median stem cell count harvested per kilogram of the patient's body weight was 4.3. And then we found some statistically significant negative correlations with the stem cell post-thaw viability and other parameters. So let's get into that a little bit. So we found the statistically significant negative correlation between the CD45 positive cells count before cryopreservation and post-thaw viability, meaning that the lower count of cells had a higher viability. And then the same pattern was seen for the CD34 cells. And we also saw the statistically significant negative correlation with the initial volume and the post-thaw viability. So I think that the message here would be that the cell count and volume after the apheresis before freezing can at some level help us predict the viability after the freezing, and whether it's going to be at least lower or higher at some point. And of course, some studies need to be done for further evaluation to confirm these. And we also analyzed the multiple myeloma patient group, and we had 110 patients with the median of 2 apheresis performed per 1 patient, ranging from 1 to 4. And then there were a median of 3 bags prepared and available for transplantation per patient, ranging from 1 to 5 bags. And also the median of 3.3 stem cell count per kilogram of body weight was obtained per 1 bag. I would like to introduce you to our workspace now, what we have in the tissue bank. So here you can see the cell processing lab, where we perform all the steps before cryopreservation. And then we have a cryopreservation and storage room, where we keep all the cells and perform the freezing. And you can see here our team during work in various stages. And I feel like it's important to mention that we had a trip to Leipzig last year, and we went there to do the stem cell separation procedure and to observe and learn how to do one. And we had very nice colleagues welcoming us, and they were very nice and helpful. And so as my presentation has come to an end, I would like you to meet our team of biologists. So going from the left, you can see me, and then two of my colleagues, Inga and Birute. And I actually hope you liked this presentation and maybe found something useful or interesting for you. So, thank you.
So thank you very much. I'm sorry for the mix-up at the beginning, but this was a very nice presentation. So actually, how long are you going? Do you have any plans for the duration of storage? Because some patients nowadays maybe leukopherase at age, let's say 50, and live and have a transplant, and then have a relapse 13 years later. So is there a cutoff to use store your stem cells for 10 years, and then discard them, or what is your plan regarding this issue?
I think initially it was planned to save the cells for 10 years, but we have not reached it yet. We will reach it in 2025 years, so I think we probably may extend that.
Yeah, because there may be some regulations in individual countries how long you can store the stem cells. But sometimes here is Dieter, and I would like to ask him whether when you store your stem cells for longer than 10 years, whether the viability goes down in the preparation. You have probably you have data available.
Yes, that would actually be very interesting to see.
We had in Leipzig, I think, to 15 years, but the licensing is only allowed to use 10 years old stem cells at the moment, but no one knows.
But this is not based on solid data, isn't it? It is just somebody said 10 years and that's it. But
you are correct. You are correct.
Sometime. Yeah. So excellent. Yeah. So what is about the correlation between volume and viability? Would you expand a little bit more on what you nicely showed us, Eva?
Well, I think we don't have enough data at the moment to make any further assumptions or anything, so we just looked at it like that, and it has to be like further studies and to confirm these findings, I think, so when it can use somewhere.
Yeah. So did you ever, because again, there are some groups who collect stem cells and then prime do the melphalan treatment, and they store the stem cells for 48 hours and then use the stem cells without the freezing procedure. So what is the status? And again, I would like to ask Peter about his opinion about this approach.
Okay, so I'm making telemedicine with Paraguay, and they are storing these cells without actually freezing 5 days. I couldn't believe this, but it's working. They don't have a freezing machine.
Yeah, of course. But it's not out of the blue actually, because but you store anyway because you have more stem cells. You would like to store them for a second, possibly second transplant or third transplant. But yeah, okay.
So I think that this is not ideal, because you still have 10% of all your patients which do not have enough stem cells, and then they are just stopped. And therefore, it's not really ideal. So I would not recommend this in a normal situation.
Okay. Yeah. Okay. So are there any questions from the floor or from the participants? No, I don't see any. So I think we then should thank Eva very much for this very nice talk, and for congratulations for the work you've done. And I think we should move forward. And who's going to introduce the next speaker? Maybe
yes.
Sandra?
Okay, so yeah, it's a pleasure for me to introduce Sergei Klimenko. He's head of the Department of Medical Genetics of the National Research Center for Radiation Medicine of the National Academy of Medical Science in the Ukraine, and professor and the chair of Internal Medicine #1. He serves as expert hematologist of the in Ukraine since 2014. He received a medical degree from the Kiev Medical University and is certified in hematology. He obtained also his MSc in radiation biology with distinction from University College in London and holds PhD and SCD in hematology from Institute of Hematology and Blood Transfusion in Kyiv. So he will talk about post-Chernobyl challenges for Ukrainian oncohematologists. I'm happy that he could join, and please, it's your turn.
Good afternoon, ladies and gentlemen. Thank you very much, Professor Niederwieser, for nice introduction of me. It's a great pleasure for me to present the data on post-Chernobyl hematological consequences in Ukraine. Chernobyl accident was the biggest so far technogenic accident in atomic nature, and the huge territories of Ukraine and Europe as well were contaminated with radioactive fallout. You can see here the maps of cesium fallout. So not only Ukraine is affected, but huge populations of whole Europe. With this talk, I would like emphasize on that not only classical consequences like direct deaths from radiation or increase in cancers occur after radioactive exposure, but diseases somehow started to behave worse, and we observe actually much more consequences on molecular level than we might expect if just projected the data from classical epidemiology. First, I would like to mention that in fact there was quite limited group of people heavily exposed due to Chernobyl accident. There were only 134 patients survived acute radiation syndrome. However, we have hundreds of thousands of people exposed to much lower doses range. With acute radiation syndrome survivors, we could observe a rather typical picture of appearance of post-radiation cancer and leukemia, with typical peaks earlier for leukemia and for cancer a little bit later. But of course, we were more interested whether the rather low doses of ionizing radiation increased the incidence of leukemia in bigger cohorts, especially in cleanup workers of Chernobyl accident. The most important epidemiological study on that is case control study performed by National Radiation Research Center in Kyiv and National Cancer Institute, US. And this study delivered the data that, in fact, and it was expected, of course, the leukemia after Chernobyl accident increase in linear dose response manner with no threshold, and excess relative risk for leukemia was equal 3.44 for cleanup workers. With longer observation, this coefficient slightly decreased to 2.38. Probably we have already moved the peak of radiation diseases. However, we still observe this increase. And if compared this data to other data on Chernobyl victims and to Hibakusha from Japan, we could see that the excess relative risks per gray is rather similar. Of course, Chernobyl data and from Ukraine and Hibakusha data is more mature because cohorts were large enough to draw the statistical significant conclusion. However, we see similar data from Russia and Belarus and Baltic countries. What was new from Chernobyl epidemiology is that first time it was proved that chronic lymphocytic leukemia is in fact radiation-inducible disease. Because for decades we considered this disease as not radiogenic induced. This data from case control study was later checked on huger cohort of Ukrainian citizens using more simple tool of ecological studies, and even with such simple tool, we were able to observe the increase in chronic lymphocytic leukemia even through decades of observation under Ukrainian populations. The explanation why chronic lymphocytic leukemia for so long time was considered not radiogenic induced is probably just the difference in probability for different population to get ill with chronic lymphocytic leukemia. CLL is rather a rare disease in Japan, and if analyze the cohort of Japanese Hibakusha, there were only 2% of cases with CLL among all leukemia cases analyzed in this group. When we move further from east to west, we could observe CLL more often in population. Therefore, the data from Teche River was also not conclusive on chronic lymphocytic leukemia increase, but with Slavic populations in Ukraine, in Russia, this increase after radiation was proved. So this study tells us that the significant association between Chernobyl-related radiation in leukemia risk exists, and CLL is radiation-inducible disease. Taking into consideration that mean doses of ionizing radiation were not that high in exposed population, only 16% of all leukemia cases were in fact attributed to radiation exposure. However, our observations are that radiation not only increases the leukemia incidence, but predetermines the clinical course and molecular genetics features of leukemia in exposed populations. We observed rather early that overall survival of acute myeloid leukemia patients is much worse in radiation-associated cases compared to spontaneously occurred acute myeloid leukemia cases. It was true for a general group of Chernobyl patients, and we even observed the trend in shorter survival with increase of mean dose for exposed population. If divided the Chernobyl populations into patients lived on contaminated territories with lower doses and to clean up workers with higher doses. The genetic study led us to find that pattern of genome-wide loss of heterozygosity probability is for Chernobyl acute myeloid leukemia samples is rather similar to mutagen-induced acute myeloid cases with high probability of involvement at chromosome 5 and 7. With this feature, acute myeloid leukemia cases developed in Chernobyl victims looks rather similar to WHO category of AML related to previous chemotherapy or radiation therapy. However, when we tell about this category, we mean dozens of gray, whereas the doses which got Chernobyl survivors are at least 2 logs lower. At this graph you can see the average doses for most affected populations, amongst which there are professional atomists with average dose of less than a little bit more than 1/3 of gray. Whereas we observe rather similar picture to AML developed after much higher doses. Other studies also led us to find some features of leukemia in Chernobyl victims. When we started to do FLT3 mutational status in our clinic, we observed that if patient had FLT3 ITD, this case was more often with several mutant alleles. We even sequenced such cases to prove this phenomenon, and this observation was the clue to higher degree of clonal heterogeneity in Chernobyl acute myeloid leukemia cases. With further study, we also observed some features of radiation-associated myeloproliferative neoplasms, for which we observed JAK2 positive mutational status much less frequent compared to spontaneous cases. However, for Chernobyl MPNs, triple negative mutational status was more characteristic, and they exhibited color 52 BP deletion more often compared to spontaneous cases. We did some additional study for triple negatives among myeloproliferative neoplasms and found that radiation exposed and unexposed patients didn't differ regarding mean number of sequence variants per patient. However, there were some interesting findings, like much more often in mutations in DTA genes, the NMT3A, TET2, and ASXL1. These were rather interesting for us because DTA genes mutations are associated with rather highly increased thrombotic risk in myeloproliferative neoplasms, and mutations in these genes are most commonly mutated in pre-malignant clonal hematopoiesis, probably before overt myeloproliferative neoplasm. Radiation-associated cases more often were presented with pre-malignant clonal hematopoiesis, CHIP, or probably they are already at the stage or leukemic transformation. Recently, there was also interesting manuscript published by Ernst et co-authors demonstrating that Chernobyl chronic myelogenous leukemias are having more mutations compared to spontaneous chronic myelogenic leukemia cases. Also with involvement of mutations like in other MPNs among Chernobyl victims. And Professor Ernst proposed some features of pathogenesis of CML after radiation exposure with more chances for patients to become resistant to TKI therapy. As a conclusion, I would like to mention that the most important, from my point of view, findings after Chernobyl is that Chernobyl accident, in spite of rather low absorbed doses for affected population significantly increased the leukemia incidence in Ukrainian cleanup workers and allowed to prove the radiogenic inducible nature of chronic lymphocytic leukemia. And Chernobyl leukemia cases more often are characterized by unfavorable clinical course, and molecular epidemiology shows much more findings compared to classical epidemiology, especially about signs of genetic instability, multiple mutations in exposed people. Thank you very much for your attention.
Yeah, thank you. Yeah. Thank you very much for this very interesting presentation. So the question pops up, did you look at hematological malignancies specifically? And did you exclude solid tumors like thyroid cancer in your survey? I was not clear, because there is this close association between radiation exposure and thyroid cancer.
Sure. With this talk, I concentrated only on hematological cancer. However, the first sign of Chernobyl consequences was the increase in thyroid cancer among children. Later, the increase in adults for thyroid cancer also occur, and we see now the beginning of increase in breast cancer. Probably we will see another cancer a little bit later.
Okay, congratulations, Professor Klimenko, and I hope you have stored a lot of samples to test molecular.
That's why I have the full freezers of them, so I invite everyone to think about this and submit some application for.
Right. So what's about myeloma?
There are no signs about myeloma incidence increase so far. However, we see some steady increase, not statistical significance so far.
Okay.
But in general, we see absolutely similar picture compared to Japanese hibakusha in terms of timing and appearance of different cancers.
Could you give us an overview about timing? When was AML diagnosed? When was CML and CLL diagnosed?
For CLL, the increase was observed rather soon after the accident, after the first decade, in fact, and it's still visible after 20 years, because it's more often disease. For acute myeloid leukemia, the increase started to be obvious approximately after eight years after accident, with peak probably after 12-13 years.
Okay, are there further questions from the audience? Not? Well, Professor Klimenko, I'm impressed about this looking up these problems, and I'm thinking that many people would like to cooperate on this issue with you. So I think we have a very nice session. Thank you very much to everybody, to the speakers, to the chairs, to the audience, and also, of course, to Aventas, which made this possible. And I think we reconvene here on 13:30. That means in about 5 minutes. So again, and goodbye for now. Bye-bye.
Bye-bye. Bye.